Good afternoon. On behalf of the NIH,
I'm sorry, Valerie, you need to unmute on Zoom. We didn't hear that. If you could start over.
Good afternoon. On behalf of the NIH Office of Disease Prevention, it is my pleasure to welcome all of you to today's event from our Prevention and Focus webinar series. This is our second webinar of 2024, and we are very excited about today's presentation. My name is Valerie Robinson, a health science policy analyst here at ODP, and I will be serving as the host for the session. As a background, first launched in 2021, this webinar series was intentionally conceived for the purpose of providing a space to hear directly from prevention research experts and thought leaders whose work is driving impactful advances in the spaces of prevention research and public health. Today, we are delighted to have Dr. Katie Bacchus-Kozhimannil from the University of Minnesota School of Public Health deliver a presentation on intimate partner violence among birthing people, the rural-urban differences and implications for safety and equity. Next slide, please. Before we begin, I would like to go over some logistics for today's session. As attendees joined the Zoom today, audio lines were muted. The lines will stay muted throughout the session. Please note that this webinar will be recorded. An archive recording will be posted to ODP's Prevention and Focus website and made available on ODP's YouTube channel in the coming weeks. There will be a question and answer session at the end of the presentation, and as stated on this slide, please feel free to submit any questions that you have to the chat pod and direct them to hosts and panelists. At any point in time, you may use the chat pod for general commentary, questions for the speaker, or to request technical assistance. We have an amazing team of ODP staff here who are closely monitoring the chat and working hard to ensure proper engagement with our speaker today. Next slide, please. With that, I know that everyone is excited to hear today's presentation. We've received an overwhelming response to this event. So at this time, I'd like to introduce Dr. Janine Austin Clayton, who will share some resources and introduce our speaker for today's webinar. Dr. Janine Austin Clayton, Associate Director for Research on Women's Health and Director of the Office of Research on Women's Health here at the NIH, is the architect of the NIH policy requiring scientists to consider sex as a biological variable across the research spectrum. This policy is part of NIH's initiative to enhance reproducibility through rigor and transparency. As co-chair of the NIH Working Group on Women in Biomedical Careers with the NIH Director, Dr. Clayton also leads NIH's efforts to enhance women in science careers. In 2021, Dr. Clayton was elected to the Board of Directors of the American Association for the Advancement of Science. And prior to joining ORWH, Dr. Clayton was the Deputy Clinical Director of the National Eye Institute for 7 years. A board-certified ophthalmologist, Dr. Clayton's research interests include autoimmune ocular diseases and the role of sex and gender in health and disease. She is the author of more than 120 scientific publications, journal articles, and book chapters. Dr. Clayton is a native Washingtonian, received her undergraduate degree with honors from Johns Hopkins University and her medical degree from Howard University College of Medicine. She completed a residency in ophthalmology at the Medical College of Virginia. Dr. Clayton has received numerous awards, including the most recent American Medical Women's Association Presidential Award. Welcome, Dr. Clayton. Next slide, please.
Thank you so much, Dr. Robinson, and thank you to the Office of Disease Prevention for inviting me to play a little role in today's amazing webinar series. I'm going to tell you a little bit about ORWH and the way we think about the topic to be presented today. Next slide, please. United States spends more money on maternity care than any other country. Yet maternal deaths have risen in the US over the last 20 years. And the risk of death from complications related to pregnancy and childbirth exceeds that of any other high-income country. Beyond pregnancy-related factors, there are a host of other contextual associated factors that are critical to consider, and intimate partner violence is one of them, as a serious public health concern with significant negative health consequences for birthing people and children. Today, with that reality in mind, we can imagine a future state where everyone has access to and receives comprehensive evidence-based obstetric care, and that all birthing people are supported in all of the ways they need to promote healthy outcomes for everyone. Next slide. And to do that, ORWH was founded to advance women's health research at NIH over 30 years ago. And these are just some very brief highlights of our activities, from developing a program designed to expand the cadre of people who do women's health research, the Birch, looking at sex differences with our specialized centers of research excellence, the NIH Sex as a Biological Variable policy, and then most recently, we just issued the new NIH-wide strategic plan for research on the health of women. Next slide. Our mission is to expand women's health research, make sure that women and underrepresented groups are included in NIH-supported clinical research, and advance women in careers. Because again, we envision a time where sex and gender are integrated across the full biomedical research spectrum, where every woman receives evidence-based diagnostics, treatment, and care tailored to her own circumstances, goals, and needs, and a world where all women in science reach their full potential. Next. And in order to do that, we are delighted, and I was privileged and honored to be in the Oval Office along with the NIH director, the president, the first lady, and others, most recently in March, for the signing of a new executive order on advancing women's health research and innovation. Two of the key aspects of that executive order are galvanizing new research, including on midlife health of women, and assessing the unmet needs to support women's health research. But as the First Lady stated during that session, quote, "We have a clear goal to fundamentally change how our nation approaches and funds women's health research," end quote. So it's an exciting time for women's health research, and I'm privileged to help lead this effort on the NIH side. Next slide, please. And from an NIH perspective, we have been investing in women's health research and maternal mortality research. Here's a graphic that just demonstrates the over $660 million investment made last fiscal year in addressing maternal mortality. And you can see the topics represented there, many of which are clinical and related to the pregnancy itself, but also topics related to perinatal care, mental health, and public health as well, which we know are critical factors. Next slide. But despite spending all of these funds, we do know that in this country, because of a wide variety of factors, maternal deaths have risen. And it was ORWH's privilege to work with several institute centers and colleagues, federal colleagues, on our recent Pathways to Prevention program, a program led by the NIH Office of Disease Prevention. And this one is focusing on identifying risks and interventions to optimize postpartum health, because we know that over half of those deaths occur after the first week after delivery. So that P2P program includes an independent panel report, click one more time for me, that is now available, an independent panel summary, as well as a systematic evidence review. And the graphic on the right highlights how important it is to consider the individual, the entire life course, the interpersonal relationships of that individual, the community context of that individual, and the societal background as critical aspects of postpartum health. Next. As related to the White House Initiative on Women's Health Research, we recently summarized some of the research and gaps related to key topics in women's health. And the topics are listed here on the slide. Two topics I want to draw your attention to in particular for today's conversation is the topic on violence against women and maternal morbidity and mortality. We also have a section on mental health and substance use as well. I refer you to these fact sheets as important ways to address some of the issues and learn more about what NIH is doing in this space. Next slide. Last month we had National Women's Health Week, a time where we focus on the health of women. And during that time, we issued another report that I want to cite for you. The U3, which stands for Understudied, Underreported, and Underrepresented Populations of Women Health Data Book. And in that data book, we highlight the health status of women from different backgrounds, including in different locations, such as rural and urban locations. And we talk about place-based environment and other structural factors that affect health, which is highly relevant to today's conversation. If you want to learn more about other ORWH websites, you can contact us on the URL on the slide and follow us on social media there. Next slide. With that, it is my pleasure to introduce our speaker for today. Dr. Katie Bacchus-Kozhimannil is the Distinguished McKnight University Professor in the Division of Health Policy and Management at the University of Minnesota School of Public Health. She is the Director of the University of Minnesota Rural Health Research Center and co-director of the University of Minnesota Rural Health Program. She also serves as a senior advisor at the Center for Anti-Racism Research for Health Equity. Dr. Kozhimannil conducts research to inform health policy that impacts critical times in the life course, including pregnancy and childbirth. And the goal of her work is to contribute to the evidence base for clinical and policy strategies to advance racial, gender, and geographic equity. Dr. Kozhimannil's research has been published in journals such as Science, the New England Journal of Medicine, JAMA, and Health Affairs, and has been widely cited. Media coverage of her work includes stories by the New York Times, the Washington Post, and National Public Radio, and has generated both dialogue and policy action at local, state, and national levels. Dr. Kozhimannil teaches courses that build skills for engagement in the policy process and works extensively with state and federal policymakers on efforts to improve the health and well-being of individuals, families, and communities starting at birth. Dr. Kozhimannil's presentation today is titled Intimate Partner Violence Among Birthing People, Rural-Urban Differences and Implications for Safety and Equity. It is my pleasure to welcome Dr. Katie Bacchus-Kozhimannil.
Hello, everyone. Good afternoon. Bonjour, Anin. Katie Bacchus-Kozhimannil, Indigene Kaz. Wenjima Jijiwang, Indujiba. Germany, England, France, Indujiba. Manto Bide, Inda, University of Minnesota, Inda. It is such a pleasure to be here with each of you today, and I want to begin by acknowledging the people that I come from and the generations of women that have come before me. I introduced myself in Ojibwe. My family comes from the area around the headwaters of the Mississippi River on the White Earth Indian Reservation and descendants of Anishinaabe people. And also I am descendant from white settlers that are originally from Germany, England, and France. And I bring that lineage and knowledge with me, that lived experience with me, to the work that I do and to the place that I am today. I come from generations of rural people, of rural women, and I acknowledge the land that I am on as the traditional, ancestral, and contemporary lands of the Dakota people. And also, I want to take a moment to encourage everyone to be aware of the lands that they're on and to consider that Indigenous people, especially Indigenous women, experience disproportionately high rates of violence, including intimate partner violence, as well as maternal mortality. Additionally, I just want to say that the context of today's discussion relates to experiences of violence, which are more common than many would imagine. These are not things that happen out there. They are things that happen in here. And I also want to acknowledge the team that worked together on this work at the outset. For many of us, intimate partner violence is something that we've experienced personally or through friendship or through family, through neighbors. And it is something that we carry those lived experiences with us into the work that we do. I encourage folks to take care as needed as we go through this context of conversation today. I have no conflicts of interest to disclose relevant to the content of this educational presentation. And I do want to acknowledge with deep gratitude the funding support that we've received from this work, especially from the Federal Office of Rural Health Policy. We also really want to acknowledge my colleague, Dr. Lindsay Admin, and also for all Pregnancy Risk Assessment Monitoring System, the PRAMS study participants who answered this survey. And I want us to remember as we move through this presentation that every data point represents a lived experience of someone who was willing to share about that. There's a whole world in every data point that we're looking at today. We have a limited time together, and I'm going to go through a lot of information, but these are the main goals that I want to anchor us today. Providing context on rural-urban disparities for birthing people generally, and then to describe rural-urban differences in reports of intimate partner violence around the time of pregnancy and childbirth, as well as screening for abuse that happens around the time of childbirth. Then we're going to take a little bit of a deeper dive into the experiences of rural residents around intimate partner violence, looking at differences among rural folks by race and ethnicity and by health insurance status. And finally, again, a lot of this is heavy, but I want to say that this is a prevention webinar. We're talking about making things better because we can. And we will talk about policy solutions for increasing safety, hope, and healing for people that experience intimate partner violence and for those of us that love those folks and that are around them. I don't need to spend too much time. Many thanks to Dr. Clayton for the helpful context and introduction. Dr. Clayton, you're one of my heroes, and it's so cool. I'm actually, when we go back to that slide, looking at the investments that NIH has made over time in women's health research, I received a Birch Scholarship as a junior faculty member, and that's part of what really launched my career in focusing on women's health and on pregnancy and childbirth care, and I'm really grateful for that. It's part of the reason I'm able to do this work today. We already know that the United States has a maternal mortality crisis. Too many moms are dying, and the data shown here indicate how pregnancy-related mortality is elevated for rural residents, that it increases with increased remoteness. Like the more rural you are, the higher the risk is of pregnancy-related mortality. Also note that this is a U-shaped curve. So we also have some elevated risk in some of our most urban central metropolitan areas as well. So looking at geography across a spectrum is very important. These disproportionate deaths are not by accident. They are preventable, and they reveal inequities that can be rectified. Being healthy and safe during pregnancy and childbirth and during the postpartum period is a challenge for residents of rural U.S. communities. This has long been true and continues to be true, with headline after headline indicating loss of obstetric services in rural communities, workforce shortages, financial challenges, safety concerns, growing risks of maternal morbidity and mortality over time, and elevated risks for rural Black and Indigenous people and families in particular. In maternity care, I want to take a moment to pause and think about the language that we use. Sometimes the very language we use to describe the problem, such as maternity care deserts, points to some of the errors we are making in tackling it. I want to point out a couple of things about this terminology. First, naturally occurring phenomena such as deserts are distinct from structurally designed, structurally shaped inequities, like places that lack access to maternity care. That's a result of decisions and policies that are made. It's not naturally occurring. There's nothing natural about where we have access to healthcare and where we don't. Those are the results of decisions that are made, and therefore they are changeable. Additionally, the use of the word desert in this context connotes a vacuous and empty space, and the US's deserts are in fact thriving environments that have been home to Indigenous people for thousands of years. Indigenous people, especially those living in rural communities, have some of the least access to maternity care. Using the term desert in this context is not only inaccurate, but it also causes further harm and erasure to Indigenous people and tribal people living on desert lands. And basically, it would be more accurate to describe places without maternity care as places without maternity care. Folks think they're using shorthand when they say maternity care deserts, but it's not accurate, and it's really only one more word to say places without maternity care. This is happening in maternal mortality. It also, the idea of a maternity care desert, a place without medical care for maternity services, it sort of focuses on access to healthcare facilities as the way to rescue moms from maternal mortality. It implies a helplessness about the situation, but maternal risk does not just derive from lack of access to a hospital care or what happens in a hospital. There's risks in homes and communities as well. And far from being a naturally occurring thing, maternal mortality that results from the confluence of violence and lack of systemic support is ripe for prevention and for investment. Intimate partner violence, abbreviated here as IPV, encompasses acts of physical, sexual, and emotional violence by an intimate partner seeking to gain power and control. Those are the key components: power and control. This can include emotional abuse, economic abuse, sexual abuse, intimidation, isolation. Violence is one of the most common health problems reported by people who are pregnant in the United States. In addition, domestic violence, including intimate partner violence, is one of the leading, homicide as a result of intimate partner violence is one of the leading non-obstetric causes of maternal mortality and morbidity. I want to take a moment to note that while physical violence is a commonly recognized form of intimate partner violence, emotional and sexual violence are also harmful and prevalent. Some examples of these include verbal insults. So emotional violence may be verbal insults, humiliation, isolation from friends or family, threats of harm, control of finances, monitoring of communication or location, stalking. Sexual violence can include forcing or attempting to force a partner to take part in a sex act, including sexual touching, or even a non-physical sexual act, such as sexting or recording, when the other partner does not consent. It's important to recognize that intimate partner violence is multifaceted, even as we move forward and sometimes in our measurement are not able to capture this full picture. I think bearing that in mind in prevention and policy work is essential. Thinking a little bit about the context of rural communities, pregnant people in rural communities face risks that may render them more vulnerable to intimate partner violence and its consequences. And this may include higher rates of per capita rates of firearms ownership and greater injuries that occur in rural versus urban communities. There are fewer legal resources, including family law, as well as there are fewer shelters, domestic violence shelters and support services, and as mentioned previously, healthcare services for pregnant people and in general. There's also higher risk of maternal morbidity and mortality and of losing access to those healthcare services that we know matter a lot for folks in rural communities. I mentioned this briefly, but I want to specifically speak to the maternal health consequences that are associated with experiencing intimate partner violence. These include higher rates of preterm birth, low birth weight, and lower rates of breastfeeding. As I mentioned, risk of the most severe outcome, which is homicide perpetrated by an intimate partner, is heightened around pregnancy and childbirth. 60% of homicides that occur around the time of pregnancy are related to intimate partner violence. This is preventable, it is urgent, it is wide scale, it is important. Since 2012, ACOG has recommended regular IPV screening during pregnancy and postpartum. And in 2018, the U.S. Preventive Services Task Force upgraded their recommendation supporting universal screening nationally for intimate partner violence and for domestic violence. So I'm going to now bring us into some of the data that we have looked at in conducting research on this topic. Our purpose was really to describe prevalence of and predictors of intimate partner violence among rural and urban residents, and later we'll focus specifically on rural residents who gave birth between 2016 and 2020. So this includes folks who gave birth at the beginning of the pandemic, but not all of the context of the various challenging conditions that arose for people that were that were or are suffering intimate partner violence in the time period of COVID. As well as we want to describe the predictors of lacking screening, of not being screened for abuse by a healthcare provider. Pregnancy and childbirth is a time when folks are experiencing a lot of contact with the healthcare system. There are recommendations for universal screening that happen, even though there is a lack of resources, disproportionately so in some communities, including rural communities. This is a time when detecting and intervening is very possible for a high prevalence and highly lethal condition. We used data from 2016 to 2020 waves of the Pregnancy Risk Assessment Monitoring System, PRAMS data, which is a survey of US residents who gave birth. The sample is representative of over 80% of births in the US, but not fully nationally representative. This analysis focused on two outcomes, whether the respondents reported experiences of physical violence. So the question was just asked about physical violence by a current or former intimate partner, and whether or not respondents were screened for physical or emotional abuse at their healthcare visits. Again, IPV encompasses physical, emotional, and sexual abuse, but this measure only includes physical violence. To measure, so the question about physical violence is shown here on the screen, and the question asks whether the respondent had been pushed, hit, slapped, kicked, choked, or physically hurt by a husband, partner, or an ex-husband or ex-partner. I pause to say the meaning of the question for a moment for us to again reflect on the fact that every person who answered yes to this is someone who is around the time, either pregnant or around the time of pregnancy or childbirth, who is experiencing those things physically in their home from an intimate partner. We also measured whether or not folks were screened for abuse. We used a PRAMS survey question about their healthcare visits and what compromised that healthcare visit, what happened during that healthcare visits. Respondents were asked whether they had any healthcare visits in the preconception period, so the 12 months before pregnancy, during their prenatal visits during pregnancy, and a postpartum checkup visits. If respondents reported having visits during this time period, which in PRAMS, almost everyone had a prenatal care visit, then they were asked whether or not a healthcare worker asked them if someone was hurting them emotionally or physically. And again, we focused on lack of abuse screening, given the importance of identifying people who are experiencing violence and are not receiving appropriate preventive care. A little bit of methods for this analysis. We used logistic regression models comparing outcomes for rural and urban residents. I want to just for a moment say the way that we divided rural and urban folks, it is obviously not a dichotomy. As I mentioned earlier, there are lots of ranges of rurality and urbanity. And what we looked at here was whether or not the person lived in a county that was a metropolitan county defined by the US Census Bureau or a non-metropolitan county. So again, that dichotomy masks a lot of variability within each category, but I wanted to be clear about how we measured that here. We looked at predicted probabilities of experiencing physical intimate partner violence, and we also estimated predicted probabilities of not being screened among everyone and among those who were experiencing intimate partner violence. We also looked specifically at why they weren't screened. Were folks not screened because they didn't go to a visit? Or were folks not screened because they were not asked a question about abuse at the visits they attended? Those two things imply different policies around ways that we can increase detection of intimate partner violence. Our sample included about 200,000 respondents who gave birth, of whom about 8,000 reported experiencing physical violence by an intimate partner. 8,000. I can't be agnostic about the experiences of the folks in the data. It's just so important. Our analysis showed that more rural residents experienced physical violence by an intimate partner. Again, these percentages may appear small, but 4.6% of birthing people, so about 4 million people give birth every year in the United States. So when we start looking at those numbers and adding them up, this is huge. These are huge numbers of people every single year that are experiencing this. The figure at the right shows proportions of rural and urban residents who reported physical abuse by an intimate partner around the time of pregnancy. We have rural residents are in blue here and urban residents in orange. Looking at this a little bit more closely, we're going to keep the rural residents in blue and the urban residents in orange. And I'm going to look at and highlight some characteristics here. So this analysis also showed that rural birthing people, there were some characteristics for which the incidence of intimate partner violence is much higher. The disparity between rural and urban folks is very wide. And a lot of this reflects what has already been known and published about intimate partner violence generally. But again, when thinking about prevention in a healthcare delivery context in rural and urban settings, it's important to know where those disparities are most stark in terms of populations that are experiencing intimate partner violence. Across most measured characteristics, rural residents had higher predicted probabilities of experiencing physical intimate partner violence. And you can see this here where rural residents had higher risks. I'm going to highlight a couple of groups here where those characteristics were different. So we can see that rural respondents who identified as non-Hispanic white, Hispanic, and primarily English speaking and American Indian Alaska Native had higher predicted probabilities of experiencing physical IPV before, during, or after pregnancy compared to urban residents with those same characteristics. Similarly, rural respondents who were younger, 18 to 34 years old, were more likely to experience physical IPV than urban respondents of the same age. And finally, and we'll come back to the role of Medicaid shortly, but rural Medicaid beneficiaries had significantly higher predicted probabilities of experiencing physical intimate partner violence compared to urban Medicaid beneficiaries. So these are folks that are experiencing violence at higher rates. This analysis here is looking at basically why people are not being screened. Is it because they didn't go to a visit, or because at the visits they attended, there was no one there that asked them about experiencing abuse? So the blue bars here show that these are of the people who are not screened, what proportion did not experience screening because either they did not receive a healthcare visit in blue, or they went to a visit but nobody asked them in orange. So we see that looking at the blue bars, we can see that most people attended a prenatal care visit. However, a high proportion of both rural and urban IPV victims did not attend a healthcare visit before pregnancy or a postpartum checkup after pregnancy. I should also emphasize here that we are looking at folks, those 8,000 people who experienced intimate partner violence. What is happening? These are folks that are experiencing physical abuse. How are they not getting asked, and when? So we can see that times of lacking visits are highest in the preconception and postpartum period, and those are slightly higher for rural residents than urban residents. But we also see big orange bars here, and those big orange bars are folks that attended these are people experiencing abuse that attend their healthcare visits and are not asked if they are experiencing abuse. Rates of non-screening for abuse are too high among both rural and urban victims, especially given recommendations for universal screening for abuse among pregnant people. More than 2/3 of rural and urban IPV victims were not screened for abuse during the preconception period. And about 1/3 of rural and urban victims were not screened for abuse during pregnancy. More than half of rural IPV victims and almost half of urban IPV victims were not asked about abuse at a postpartum checkup visit. So even looking across the entire pregnancy period, more than 20% of rural respondents were never screened for abuse during the 3 stages of pregnancy. That's compared with roughly 16% of urban IPV victims. And during each stage in pregnancy, rural IPV victims are less likely to be screened than urban IPV victims. Again, apologies for the very busy graphic. You can look at the published papers if you want more details on this, but there are, this shows the predicted probabilities of screening for abuse. Again, you can see all of them are just very, very low. They are very low. Across some of the measured characteristics, rural residents had higher predicted probabilities of non-screening than urban counterparts. And I'll highlight those here. So again, we can see that some rural-urban differences were more pronounced. Among IPV victims, rural Medicaid beneficiaries had higher predicted probabilities of lacking screening, of not being screened, compared to urban Medicaid beneficiaries. And again, younger rural victims were less likely to be screened for abuse than their urban counterparts. And finally, rural victims who were unmarried at the time of childbirth, these are folks who are experiencing intimate partner violence, had higher predicted probabilities of not being screened for abuse around the time of pregnancy. So briefly, what we're seeing here is that intimate partner violence before or during pregnancy is more common among rural US residents compared with urban residents. Among those who experienced IPV, a higher proportion of rural residents are not screened for abuse at all during the perinatal period compared to urban residents. More than 1 in 5 rural IPV victims is never screened for abuse in the year prior to, during pregnancy, or in the postpartum period, despite all of the contact that they likely have with healthcare systems during that time. I'm going to pivot now, and I'm going to briefly talk among rural folks at some of the, as I said, the rural group is a large group, first group of people. There are many different types of rural folks. 1 in 5 rural residents is Black, Indigenous, or a person of color. And they're also, as we know, Medicaid covers about half of all births nationally, but that proportion is higher in rural areas, and there's variability across rural communities in terms of income and insurance status. Rural residents are also much more likely to be uninsured and to go through insurance churning. So we're going to look at those two aspects: racial and ethnic differences in intimate partner violence among rural residents, and then insurance. And then we'll move forward into some discussion. And I also am aware of time, and I really want to make sure that we leave time for discussion and questions, because I want to hear from all of you about your thoughts on this as well. So I mentioned that approximately half of homicides that occur during pregnancy, 60%, are related to intimate partner violence. Available data indicate that Black birthing people experience the highest rate of pregnancy-associated homicide, and American Indian Alaska Native people experience the highest rates of intimate partner violence overall of any racial or ethnic group. Data reporting practices frequently eliminate Alaska Native and American Indian folks or Indigenous folks as a racial and ethnic category, suggesting a likely undercount of pregnancy-associated homicides among Indigenous birthing people. And I want to elevate that again. It is so important that when we are looking at health equity and health disparities, that we, even with all of the limitations in the American Indian Alaska Native category, that this category is not erased or put aside, that it is at least discussed, and that the data are presented whenever possible to do so. We know there are racial inequities in access to maternal health care. Our own work on maternity unit closures has shown the least access to obstetric care in rural communities that are a higher proportion of Black or Indigenous residents. And we know that both of these things come together to potentially produce inequities. And indeed, we saw inequities here that were reflective of other studies that have been done on racial differences in experiences of intimate partner violence. Briefly, we found higher rates of intimate partner violence among multiracial and among Alaska Native and American Indian, Indigenous rural birthing people compared to non-Hispanic white rural respondents. These were very high rates in these populations. Interestingly, results for screening were different. Among all rural birthing people, non-Hispanic white birthing people had higher rates of, so this is among all rural birthing people, not just IPV victims. Non-Hispanic white birthing people had higher rates of lacking screening compared to BIPOC respondents, so Black, Indigenous, and people of color respondents. This includes those who were not screened because they didn't have a visit, and because they were not screened because they attended a visit and weren't asked about abuse. The figure shows the results for all birthing people, but we did conduct a similar analysis among IPV victims and found a similar pattern of elevated risk of lacking screening among non-Hispanic white rural IPV victims. And this highlights how racialized patterns of access to care and implicit bias among providers may manifest in risk to all racial groups. Providers may be aware of higher rates of intimate partner violence among American Indian Alaska Native folks, for example, but in a time when universal screening is what's recommended, if they're not asking everybody, then we're seeing racial inequities fall on non-Hispanic white individuals in rural areas who are less likely to be asked about abuse, even among IPV victims. As I have described, intimate partner violence is elevated among all rural residents, but postpartum health insurance, and especially as we looked to the development of postpartum Medicaid extensions for 1 year postpartum, that's something that's very common. It's happening in almost all states now. And we conducted another analysis to really look at insurance churn and differences in those who experience IPV and go through health insurance churning if they are lacking screening, or if the folks that are moving in and out of health insurance coverage are folks that are more likely to be experiencing intimate partner violence. How do we think about that in an era where we have an opportunity associated with pregnancy-related Medicaid eligibility extensions to 1 year postpartum? So we again use data from the 2016 to 2020 pregnancy risk assessment monitoring system to look at self-report of physical violence and rates of abuse screening at postpartum visits. So here we're looking at abuse screening only in the postpartum period. And we looked at health insurance at childbirth and postpartum. We categorize that as either private, Medicaid, or uninsured. There's more details on exactly how we measured this. It's consistent with prior studies that other colleagues have done looking at how to create categories of different types of health insurance. And there's more detail on that in the paper. But we looked at each of these time points and also at insurance transitions from childbirth to the postpartum period, specifically looking at those who had continuous private health insurance, continuous Medicaid coverage, those who transitioned from having Medicaid to having private insurance coverage, and from Medicaid to being uninsured. This is, again, a time period before those postpartum Medicaid extensions were enacted. So what we can see here is those that are transitioning from Medicaid to private insurance or Medicaid to being uninsured are folks that could potentially be reached differently by Medicaid services or by the continuation of those in the future. Importantly, intimate partner violence rates, this is reports of experiencing intimate partner violence. Intimate partner violence rates varied by health insurance status at childbirth, with the highest rates being among Medicaid beneficiaries, 7.7%, compared to those who were uninsured, that was 1.6%. And this may be because there may be a lot of reasons. This is also a very small population of folks who are uninsured at the time of childbirth. The same rate, 1.6%, is true for the folks who are privately insured. This is a huge, huge differential of higher risk reported among folks who have Medicaid coverage. The trend was similar, health insurance postpartum. When we looked at the insurance transitions, the highest IPV rates were reported by those with continuous Medicaid coverage, followed by those who transitioned from Medicaid to private insurance or Medicaid to having no insurance or being uninsured postpartum. So we can really see here that this population that's served by Medicaid programs is at much higher risk of experiencing perinatal intimate partner violence. Nearly half of rural residents lacked postpartum abuse screening, the highest proportion among rural residents who were uninsured at childbirth. This is not surprising that this is 66% of those folks, or those who were uninsured postpartum. Obviously, this descriptive research is heartbreaking, and it points toward the specific groups that suffer the most and toward whom we should direct prevention and support. To that end, to complement these quantitative data analyses, we conducted key informant interviews with staff members from 15 intimate partner violence victim support and advocacy organizations. 5 were nationally serving policy and advocacy service organizations, and 5 were state-based coalitions in Maine, Minnesota, North Carolina, South Dakota, and Wisconsin. We also surveyed 5 direct service organizations that are operating in rural communities and that serve rural intimate partner violence victims. When we did this, we conducted these interviews. Okay, they're all on here. I'm going to move on to tell you a little bit more about what these folks said that highlight why we are seeing the quantitative findings that we are seeing. In their words, this is what we heard. These are quotes that relate to kind of power and control and the enhanced risks that rural people face. I think there's a real reality in our movement that domestic violence and sexual assault do not exist in a vacuum, and they exist because of the societal structure that we've created, which is a patriarchal structure, a structure of oppression, a structure where we're not talking as much about gender-based violence as we're talking about power-based, and we're not talking about power-based violence. People hold that power, you know, and are perceived to have more rights to behave the way they want to. How do you hold power accountable when you're not in power? One of the greatest challenges for clients for risks in a rural area is being in a rural area. Rent is outrageous compared to wages, as so many victims choose to stay with their abuser for the lack of financial resources elsewhere. They can't leave. But I have hope. I have a lot of hope. And so do the people that we interviewed and work with. Let's transition to a brief discussion of the implications of this research, and then we'll move on to Q&A very shortly. Oh, I just want to talk about all the efforts to improve access to safety, hope, and healing for all rural residents and all people, all intimate partner violence victims, and all of us who love those folks and all of us who are those folks. There are barriers to universal abuse screening. That's one of the most important clinical implications here. For clinicians, barriers to abuse screening may include lack of knowledge about how to screen for intimate partner violence, discomfort in screening for and discussing IPV with patients, especially if they live in communities where there are limited or no resources for those folks, little time to screen for intimate partner violence during healthcare visits, a lack of accessible referral resources. And these barriers are amplified when patient-provider interactions in rural communities, this given access challenges, such as distance to care, as well as workforce shortages, and especially among rural IPV victims at greatest risk of not being screened. So some of the folks that are, these are the folks that are unmarried birthing people, younger birthing people, lower income birthing people, those with Medicaid coverage. Policymakers and health systems leaders should consider strategies that address these barriers to achieving universal screening, especially for these folks. Regarding screening policy, one of the folks that we interviewed said there's no statewide statute in our state for mandatory training for healthcare professionals on domestic violence or domestic violence screening. There's still large numbers of professionals in our trainings who said they've never received training on domestic violence. So I think there's a lot of missed opportunities for screening survivors and responding to domestic violence. I think that having this in policy would be really helpful toward rural victims who are pregnant and postpartum. I want to take a moment to pause on health insurance coverage. I've talked a bit about this, but health insurance coverage has included abuse screening without cost sharing since the implementation of the Affordable Care Act in 2010 and the implementation of the Women's Preventive Services Amendment. Ensuring access to this health insurance coverage and access to care in the preconception and postpartum periods in particular will help facilitate financial access to healthcare and thus an opportunity for screening. So we need clinicians to be more comfortable and well-equipped and trained. It should be part of medical training for anyone who takes care of birthing people. It should also be a part of clinic policies and procedures and healthcare delivery systems and integrated with community resources. And people need to have both health insurance coverage and access to actual care, because health insurance coverage is access in name only if you don't live anywhere near someone who will see you when you're pregnant or will screen you or will provide support services if you do screen positive. Rural residents are disproportionately likely to experience uninsurance in the postpartum period and insurance disruptions, and so would likely benefit from, the continuous access to Medicaid coverage. And also these groups are the groups that we can focus policy in order to enhance screening, universal screening, and potentially also connecting folks to resources through creative solutions. Just bolstering the funding and services that are available in rural places would support the health and safety of rural IPV victims, such as access to affordable housing and jobs that provide living wages, access to childcare, and access to other things the federal government can do, like tax credits for children or low-income individuals. The folks that are doing this work in the field have excellent ideas about policy solutions. Now, policy implications for prevention are also important. Our research revealed racial inequities in the experiences of IPV among rural residents, with the highest risks among American Indian and Alaska Native folks. Our research also showed that rural residents who are insured by Medicaid before or after childbirth are at elevated risk. Uninsured individuals also had elevated risk. Thinking about one of the key things that came up when we talked in our interviews with providers is the importance of centering victims, of victim-centered prevention and support services. So efforts to address prevention of violence is needed in low-income communities, among uninsured people, and in rural and tribal communities. And those resources need to be directed in a way that is victim-led, and is sensitive to the fact that you can't just tell people to leave when there's no place to go. And that there may be other things, other structural issues at play that constrain the choices that people have, and people are doing the best that they can to survive. And so honoring and centering that in the work that we're doing in terms of prevention is essential for not repeating mistakes that we have made in the past. On the research side of things, how to prevent IPV, we don't have a lot of good evidence on programs that work at scale. We have good evidence of prevention in smaller scale, but not at a policy level in the way that we really need to address this as a public health crisis, as Dr. Clayton mentioned at the beginning. But we need more research on victim services, batterer intervention programs, as they're sometimes called. So this is the prevention, working with folks so that they don't become abusers, healthcare provider trainings and requirements and support for healthcare providers, health insurance benefits and coverage, including the integration of other types of services and support outside of clinical settings, and coordination across sectors. So coordinating between family court, law enforcement that's often involved in domestic violence and intimate partner violence, and healthcare settings. There's just nothing like listening to women, because their lived experience is just so vital, and it has to be heard. The foundational layers of structural oppression and structural inequity end up impacting survivors in so many ways that approaching this kind of violence from an individual paradigm, victim services only, and this is me adding, it really just leaves people to continue to experience harm, generationally speaking, or at a community level. So much of our work right now focuses on individual level interventions, getting victim support services for one individual, getting screening for one individual. We need to transform systems to truly make the changes that people need and deserve. Intimate partner violence is too common and incredibly dangerous, and many victims aren't ever even screened. Intimate partner homicide is a leading cause of maternal mortality, and every pregnant person who is physically, emotionally, or sexually hurt by an intimate partner deserves, at the very least, to be asked about this during healthcare visits, and ideally also to be supported and safe outside of the healthcare setting. Maternal mortality is a crisis in rural communities and across this country, and intimate partner violence is a contributor. Policy efforts to address intimate partner violence among rural residents could focus on universal abuse screening during healthcare visits and continuous health insurance coverage, as well as targeted support for communities that are at greatest risk in rural communities and across the country before, during, and after pregnancy. I'm putting up here the slide for the Rural Health Research Gateway for more resources on this work. You can get all of this work available there, and any other resources on rural health and rural communities, which I would encourage you to take a look at. I would like to end by saying thank you, Chi-miigwech. There are some resources that are available here, and I am so glad to be with you and glad to have a chance to address some questions. Thank you so much. I'm now going to pass it back. It looks like Valerie is going to move us forward. Thank you.
Thank you, Dr. Kozhimannil, for your important and informative presentation. As you can imagine, there are lots of questions and comments in the chat. So as a reminder to attendees, please continue to submit your questions to the Q&A pod directed to all panelists. And as you continue to think about these questions, I also want to take the time to ask that you save the date for our next webinar presentation coming your way on July the 22nd, and the topic will be on menthol. And now I'll move on. If you can go to the next slide, I'll move on to introducing our Q&A moderator for today's session, Dr. Rosalind King. Dr. King joined the NIH Office of Behavioral and Social Sciences Research in 2023 to supervise the scientific program planning and coordination activities. In this role, she supports the OBSSR mission to enhance the impact of health-related behavioral and social sciences research and coordinate and integrate these sciences throughout the NIH. And prior to coming to OBSSR, she was the Associate Director of Prevention at the NICHD for 5 years and a Program Director in the NICHD's Population Dynamics Branch for 20 years. Dr. King obtained her PhD in Sociology and Demography from the University of Pennsylvania and completed a postdoctoral fellowship at the University of North Carolina, Chapel Hill, with the PIs of the National Longitudinal Study of Adolescent Health. Dr. King, welcome, and the floor is now all yours for Q&A.
All right. Thank you so much, Valerie. While I do this, if I know y'all like to end close to time, so if someone could put in the chat for me how long you want this to go, that would be great. So thank you so much, Dr. Katie. I'm going to mess up your name.
It's fine.
Say Katie.
It's okay.
I've been privileged to follow Katie's research for nearly 2 decades, and I'm just such a fan. It's always informative.
Roz was my first project officer at the NIH ever.
So I know there's lots of questions, and like I said, please do put them in the chat because we're not going to get through all of them, and ODP will try to collect them and disseminate them for later. I did notice several of the questions were about directing people to resources, which I think you just addressed with the website. So I'm going to move past those and go to one that came through a little earlier that asked about people recognizing that they're being screened. Do patients really understand what's happening, and then so reporting in the data?
Yes. We did not do surveys specifically with folks about this question, so I'm going to answer it based on the evidence that I have read and anecdotally what has been discussed. People who are experiencing intimate partner violence are highly vigilant about their situation and about protecting themselves. So they are monitoring all the time for what is being asked and what is safe to share. And oftentimes people do understand what they are being asked, and their response is tailored to how the question is being asked and how open they believe the person asking the question is to hearing the truth, and if they're ready and able to do that. And so I think there are a lot of complicated dynamics that go into this question of were you asked, were you screened? Because people can ask that question in a variety of different ways. And I also have a ton of empathy for the clinicians that are doing this screening in a context where they are terrified of getting a positive screen and having someone say that, yes, I am experiencing violence, because it's difficult to know what to do. And without those resources in place, everyone is in a bad situation. I also want to acknowledge that many of our healthcare workers are not immune from experiencing these things themselves. So I do think it is, people who are victims know exactly what they're being asked when they're being asked it, and they are making calculated assessments of their own safety and well-being and whether or when and how they can share.
Thank you. Another question is someone who's a clinician who works mostly with males in the justice system, typically post-incarceration, asks if there's anything you recommend to aid screening from that standpoint.
Yes. Oh, I'm so glad for this question. There has been very limited research in this space. They're often called batterer intervention programs, as I mentioned earlier. It's the older nomenclature. Dr. Lundy Bancroft is a leading researcher who has written about this and has conducted some of this research, which I think is really helpful. It's so important that folks who hurt people, right? But then how do we stop those cycles? And especially folks that have perpetuated violence, what is the healing mechanism for them and the reintegration for relearning and being a safe and healthy person out in the world? I think that's a wonderful, deeply important place to begin. And I think that's also an important place, not just for folks that have been like court ordered to undergo batterer intervention programs, but especially for prevention, for teaching people about safe and healthy relationships and what is appropriate and what is not appropriate, and how to make amends and how to communicate about it when people are right on the edge of those things.
Another question, since you did mention policy.
Yes.
So someone is asking in the chat about healthy marriage and responsible fatherhood program funded by the Administration for Children and Families. And have you linked your thinking in this area to the implications of those kinds of policies?
I don't know that program in particular and haven't studied it. And in general, I think it is challenging to figure out how to navigate autonomy and relationship building. I think sometimes by the time we are talking about marriage, it is too late. Some of those ideas around relationships have already been formed. So a lot of the work that I've seen that's been very promising has focused on earlier in life in terms of sexual health education and dating, which again varies a lot across policy settings in the United States. And therefore the ability to conduct those types of programs is really challenging. It's incredibly important that we do research on these programs and start to understand what can work and be scaled up and be sustainable, not just as a standalone grant-based program, but like something that everyone gets all the time. That's especially important for rural communities because these program-based interventions tend to be funded, often by foundations that fund things that will reach the most people. And that's never going to be a rural community. And it's especially not going to be like a rural tribal community where you just have lower population density. And so we need to think about also targeting folks that are at greatest risk, not just reaching the most people.
Right. Thank you. I also want to note in the chat that ODP staff did post some links to some notices of funding opportunity that people
Great.
may want to look at. And I think, unfortunately, I need to hand this back to Valerie.
Yes, sadly, we are at time. Lots of great information today. I want to thank you. There is a slide on the screen with OBSSR events if you all want to take note of those. I apologize, Dr. King, that we were not able to get to that slide today. Next slide, please. So thank you again to our awesome presenter, Dr. Kozhimannil, for elevating this important topic on intimate partner violence. Thank you, Dr. Clayton, for the wonderful introduction and debrief of the phenomenal ongoing work of ORWH, and Dr. King for the engaging Q&A session. Thank you to my ODP colleagues, Catherine, Melissa, Teresa, Winnie, James, Katie, and Michael, who worked together to make this webinar possible and run smoothly. Thank you all for your extra time. I know we're a couple minutes over, and an additional thanks for all of you again for joining us today. If you have any questions, feel free to contact us via email at preventionandfocus@nih.gov. We'll see you July the 22nd for our next webinar on menthol. And thank you all again for attending. Thank you, everyone.
Thanks, everyone.